Hello and welcome to the session today, which is based on wound assessment. My name's Ellen Buckley and I'm a tissue viability nurse advisor with Coloplast, and I'm really excited to be able to present this to you today because it's a topic that I'm so passionate about. So if we just look at the learning objectives that we should hopefully work through during the session, and we'll recap them at the end just to make sure that we've covered everything that is on this slide here in front of you. So after completing the course, you should be able to have an appreciation of the importance of what it means to do a detailed wound assessment, how important it is. We need to be able to identify barriers to healing using the Triangle of Wound Assessment, and think about how important it is to make sure that we accurately document our assessment that we've done for our patient, and have an understanding of why now more so than ever, thinking about shared care approach to our patients' wound management is really important. At Coloplast, we like to keep things as simple as possible. Why make things more complex than they need to be? And the Coloplast three-step approach is designed to simplify that whole wound management process. So step one of the Coloplast three-step approach is doing a really robust and systematic assessment to help us to identify what barriers there might be to healing and to come up with treatment aims for that wound management of that patient. And then once we've done our assessment of our patient, we've identified barriers to healing, we need to think about how we remove those barriers. What within that management plan are we going to do to help progress that wound towards its final stage of healing? And then once we've prepared our wound, after doing our assessment, we need to have a robust treatment plan, a management plan. What dressings are we going to use to achieve what it is that we identified we needed to achieve as part of our assessment? So why do we do a wound assessment? Well, we need to know why the wound is there. If we don't know why that wound is there in the first place, then we're likely not to make a good decision about how to manage that wound or to progress it towards healing. We need to identify any risk factors that might be there for that patient. Some patients might be more at risk of infection, for example. So we need to know that as part of our wound assessment so that we can tailor our management plan to reduce the risk for that particular patient. Some wounds are there because of underlying causes. We might not be able to completely remove those underlying causes, but we need to try and alleviate those underlying causes where it's possible to do so. And an example of that might be a venous leg ulcer, for example, where there's underlying venous disease which is causing that wound not to heal, or a pressure ulcer, for example, where there's unrelieved pressure, which again is going to delay healing for that particular wound. So we need to know about those as part of our assessment. Not all treatment options are suitable for all wounds, so we need to understand what treatment options are suitable for different wound etiologies and different wound types. An example of that, again, might be a venous leg ulcer or an arterial leg ulcer. So the nature of both of those etiologies of leg ulceration are treated very differently, and we can cause problems if we make the wrong decision in treating that kind of wound etiology, as we can with lots of different wound etiologies. We need to control any symptoms that might be problematic in that wound. That might be pain, that might be odour, that might be excessive exudate that's leaking outside of that patient's dressing, for example. And we can identify these problems and symptoms, again, as part of our robust wound assessment. We don't want anything we do to make things any worse, so we need to make sure that the treatment options that we choose are not going to, cause that wound to be further delayed in healing. So if, for example, we identify that the wound has a low exudate level, for example, and we put a really highly absorbent dressing on that wound, then we could potentially cause trauma to that wound if that dressing sticks to that wound bed. So that will, our robust wound assessment will help us identify issues like that as well. We need to understand what the patient's expectations are as well. Some patients can be quite challenging in that, their expectation is that, they don't want their wound to heal, and that can be a real challenge. Sometimes that might be that they consciously don't want their wound to heal because they enjoy that experience of having that healthcare professional see them at that clinic appointment or visit them in their house. So that can be a challenge. Sometimes, the patient has an expectation that you will use a certain dressing, for example, that you might not feel is an appropriate dressing for that patient's wound. So understanding what their expectation of their wound management plan is really, really essential as part of that assessment. And I mentioned before about shared care, but never more so than now are we in a situation where we need to promote patients being more independent in managing their wounds. So the frameworks that we're going to talk about as part of this session will help us improve our clinical decision makings for the patient with the wound. It'll help us make our clinical outcomes more achievable because we will have clearly identified as part of the assessment what those clinical outcomes should be. It will help improve cost effectiveness because if we do a robust assessment and we make good decisions about that patient's wound management plan, then that wound is likely to heal quicker. We're going to make better decisions about using more cost effective dressings. We will identify, as I said before, the patient's expectations and we will facilitate better communication between ourselves and the patient and between clinician to clinician as well to promote continuity of care. So how often do we do a wound assessment? Well, that will very much depend on the condition of the patient and also the condition of the wound and the care setting where that wound has been looked after. But a holistic wound assessment should be at minimum every 2 weeks in the acute setting or every 4 weeks within a primary care or community setting. So what happens if we don't get it right? Well, inadequate wound assessment might mean that we don't identify those factors or barriers to healing which could cause that wound to be there for longer. We might make inappropriate treatment choices, as I alluded to before, with compression therapy, for example, and leg ulcers. And the patient might develop complications such as infection if we don't do an adequate wound assessment and identify any risk factors, for example, for that patient. The wound might be there for longer, and that's going to have an impact on the patient, and it's going to have an impact on our resources and the wider healthcare economy. And the longer the wound has been there, the more costly then that wound is going to be. So we need to do a careful assessment to make sure that we can, alleviate these issues. It's not easy to do a wound assessment, and it's not something that we automatically all know how to do, and it can be a really complex process. But what we do is that we can split wound assessment into 4 distinct areas. We can split it into patient factors, factors within an organisation, and educational factors, and also factors specific to the wound itself. So wound-specific factors might be, how deep the wound is, what are the dimensions of that wound? Is there a good enough blood supply to that wound? We need blood to be able to heal the wound, so, what is the perfusion to that wound like? Is there any devitalised tissue on the wound that we need to, remove because it's going to cause us a problem in that healing process? What level of exudate is there? Some factors specific to the patient themselves. Some patients have lots of different comorbidities. How painful is that wound, and is that having an impact on that patient that we need to do something about or help to manage? Patients with wounds can often become quite socially isolated because they might be embarrassed about having a wound, because it might be leaking onto their clothes, for example, or there might be some odour associated with that wound. So we need to understand what all of these factors are as part of our wound assessment. Educational factors, some organisations provide really robust education in tissue viability, wound assessment, wound management, but some organisations, clinicians don't have access to that education to help them do a robust wound assessment, for example. Some people in organisations might have a negative attitude, or they just might not be interested in wound management and can be quite apathetic. Lack of education can lead to ritualistic practice or traditional practice which might not be evidence-based. So we need, through education, to make sure that we are delivering an evidence-based wound assessment and evidence-based subsequent management of that wound. Some organisational factors might be that there is an inappropriate skill mix, for example. So on a ward setting, for example, there might be just 1 or 2 people who have some knowledge about wound assessment. What happens if they go off sick or if they're on annual leave? That patient's wound assessment is possibly not going to be as good as it should have been. Inadequate resources, we don't have the time or the staff often, to make sure that we can devote enough time to doing an adequate wound assessment and managing these patients and understanding what all of the potential problems might be for this patient. In some organisations, there isn't as many clinical guidelines devoted to wound assessment and wound management as there should be, so that can cause us a problem as well. So we have things called wound assessment frameworks, and because wound assessment is so complex, we need to make sure that we do a wound assessment in a systematic way with a structured approach to capture all of the information that we need to capture to make good decisions about how to progress that patient's wound towards healing. Now, this is a timeline of wound assessment frameworks, and the earliest wound assessment frameworks you might be familiar with was something called wound bed preparation. So the wound bed preparation framework was a tool which helped to give some structure to wound assessment, and the areas of the wound that it looked at were predominantly debridement. So is there any devitalised tissue within that wound that needs to be removed to help that wound to progress? How much exudate is coming from that wound? Is there any swelling that we need to be concerned about? And are there any signs and symptoms of infection that might be causing a problem? So maybe it didn't look as wide aspects of the wound that we needed it to, but it did give some structure to the wound assessment to help guide clinicians to making decisions about how to progress that wound. And then a couple of years later, TIME, which was developed from the wound bed preparation wound assessment framework. So TIME looked at tissue types. So was there any tissue or non-viable tissue that needed debridement or removal from that wound bed? It also looked at signs and symptoms of infection. So what was the bacterial load like on that wound? How much moisture is there? So exudate levels for the wound. And it looked at the edge of the wound, which was new from the wound bed preparation, because it was identified that wounds will epithelialise from the edge, so we need a healthy wound edge to help that wound to progress towards healing. So that was quite new. And then more recently, in 2015, we had the Triangle of Wound Assessment developed. And the Triangle of Wound Assessment was developed in response to a more global study of clinicians and healthcare practitioners who really highlighted that we can't just look at the wound bed and be blinkered in just looking at the wound bed itself. We do need to look at how healthy that wound edge is, and we also need to look further afield because we need to look at the surrounding skin or the periwound skin as well as part of our assessment. So the Triangle of Wound Assessment is a holistic assessment tool, and it firstly gives us the opportunity to do that holistic assessment of our patient. So looking at things like comorbidities, medications, diet and nutrition and hydration for the patient, blood supply to the wound. So once we've done our holistic wound assessment, we then focus more clearly on the wound bed, the wound edge and the peri-wound skin. So when we look at the wound bed, we're essentially looking at, tissue type again. So what colour is that tissue? How much of it is there? Is that something that we need to incorporate into our management plan because we've identified that there's devitalised tissue that needs to be removed? We also look at exudate, and we also look at signs and symptoms of infection that might need to be incorporated as part of our wound management plan. So once we've done our wound bed assessment, we then look at the edge of the wound. And these are the common problems that we might see at the wound edge. So maceration, for example, dehydration. Is there an undermined wound edge that we need to take into account as part of our management plan? And what are the edges like in terms of, are they thickened or are they rolled? And then we move again further afield to the peri-wound skin with, again, maceration, common problem on peri-wound skin, or excoriation. Dry skin can be a problem on peri-wound skin. So when we do the assessment on these three different areas, it helps us come up with management objectives that we incorporate into our treatment plan. So the management goals as part of your wound assessment: if you've identified that there's devitalised tissue at the wound bed, then your management goal would be to remove that non-viable tissue, because we know that as long as that's there, it's going to cause us a problem in progressing that wound towards healing. We need, if you've identified that there's some signs of infection, the bacterial burden is something that we're going to need to manage. And again, on the wound edge, if there's high levels of exudate, then that's going to put that wound edge at risk of maceration, which is not what we want to happen, because that will, again, delay that wound healing process. So that would be incorporated into management of that exudate, would be incorporated into our management plan for the patient. And of the periwound skin, for example, if you've identified that it's dry skin, then an emollient might be something that you would incorporate into that patient's wound management plan. But just as we go through this presentation, I'd like you to have a think about your patients, any patients on your caseload that you're currently treating with a wound, and do you specifically look at these different areas and come up with a robust wound management plan after identifying those barriers to healing using a systematic framework? So what are we doing as part of an assessment? Well, essentially we're trying to gather information from the patient, and the patient will give us a lot of information, and we use that holistic approach to do that assessment. So we're gathering information to try and find out and be that detective to try and come up with any problems that we might run into as part of that wound healing process for that patient. And we do that firstly by taking a patient's history. So gathering all of that that information by asking the pertinent questions that we need to ask of that patient. And only after we're doing this should we be doing an examination, a top-to-toe examination of that patient. So we use our ears, we listen to our patients, don't we, to establish that clear history. You know, what are the patient's main concerns? And listening to the patients will help us identify those factors that might delay healing. And it also helps us to establish a rapport with the patient and family. We're gathering that information by taking that history, and it helps us to identify what that possible clinical diagnosis might be for that particular wound, or exclude a diagnosis that we might have been concerned about. It will help us explore what the problem is from the patient's perspective, because what we think might be a problem for the patient might not actually be the case, and the patient might have different ideas about what the problem is for them. It will help us establish, you know, the duration, you know, how long has that wound been there? Is there a pattern of reoccurrence of that wound, for example? So a venous leg ulcer, as you can see here, sometimes, you know, they can recur quite frequently. So we need to understand what the pattern of that wound is for that patient. As I alluded to earlier, you know, we ask about medications as well. We need to make sure that we have a full list of that patient's medications, because some medications will delay that wound healing. As we know, steroids, for example, reduce inflammation. So if you've got a patient who is taking steroids, whether that be oral steroids or topical steroids or inhaled steroids, then they're going to have a reduced inflammatory effect. And what we know is that as part of the wound healing process, the second phase of wound healing is the inflammatory phase. So if you've got a patient who's taken a tablet or a medication that will reduce inflammation, are they going to have a normal inflammatory phase of wound healing? Probably not. So we need to understand what medications the patient is taking. We need to check how often they're taking them, what dose they're taking, are there any side effects to those medications? And are they taking them, you know, are they compliant in taking that medication? Because sometimes that patient's medication might be written on their prescription, but sometimes it's that they're not actually taking that medication at all. So we need to know all of that information. So once we've gathered all of our information by asking those questions of that patient about medications and comorbidities, etc., we then need to do a skin inspection. We need to do that top-to-toe examination of that patient, because sometimes doing that full skin assessment and not just focusing on where the wound is can uncover problems that might hinder that wound from healing itself. So an example of that might be a pressure ulcer on a patient's heel. We know that that's where that pressure damage is, but we also know that there are other potential at-risk areas of pressure damage, and if there are other signs of pressure damage elsewhere on the body, then doing that top-to-toe assessment will really, really help. But it's not just using our eyes. You know, we use our hands as well when we're doing assessment of a patient, whether that be feeling around a pressure ulcer to try and feel if there's any more signs of pressure damage, whether it be feeling the temperature of the skin surrounding the wound, which might be, you know, if the skin feels warmer than adjacent skin, that might be a sign that there's some infection. Or if we're doing a leg assessment, for example, and the limb feels really, really cold, that might be an indication that there isn't as good a blood supply as we would like get into that wound. So it's really, really important to use our hands as well. We can also, using our hands, feel the texture of the skin. You know, is it rough? Is there any induration? Does the skin feel quite dry? You know, is it moist? You know, if you're doing a leg assessment, you might be able to palpate if there's any foot pulses present as well, obviously using your hands. We can do an assessment of any swelling using our hands as well. You know, is that, if there's edema there, is it pitting or non-pitting edema? Is it dependent edema? As I alluded to before, what temperature is the skin? Is it cool? Is it warm? All of this really good information will help us form a good management plan. So before focusing on skin integrity or the wound, you know, we need to assess the patient's general appearance as well, because that can also tell us an awful lot. We need to obviously notice the patient's age. We would have access to that information, so we would probably already know that. We need to know what the patient's weight is, perhaps, what their mobility status is. You know, do they come across as being anxious? Are they tired or confused? All really good information that we need to record to help us formulate that management plan. And sometimes, you know, having those good observation skills will help, you know, give us that additional information, which will, you know, help us, assist us when trying to make that diagnosis of what that wound actually is and come up with that management plan. The dressing that we remove from the patient's wound can tell us an awful lot about that wound. You know, is the dressing saturated, which might be an indication of how much exudate is coming from the wound? Is it stuck to the wound bed, in which case, you know, is it a low exuding wound? Is there any odour, you know, which might be a sign that there's an infection that we need to do something about when we come up with our management plan. So the dressing can be really, really useful. I spoke about malodour. You know, an odour, you know, might be an indication that there's poor personal hygiene for the patient. It might be an indication that the patient is suffering with incontinence. So is that a conversation that needs to be had as part of the wound assessment? And you know, it can be a sign of an infection, as I said before. So you know, benefits of smell should not be underestimated as part of your wound assessment. Smell is the first human sense that clinicians use subconsciously when we're assessing a patient's skin. And as I said, it provides us with some really, really useful information. But wound odour can really, really affect as well how patients can, you know, relate to loved ones and friends, for example, and can be a major cause of low mood and social isolation. So it really shouldn't be underestimated, you know, if the patient is suffering with an issue with malodour of their wound. So wound assessment, it's not something that we just do as a one-off, it should be an ongoing thing. A wound assessment, it's a continuous process. So we do our wound assessment, we come up with a management plan because we've identified barriers to healing or aims and objectives, and then we put a management plan in place. But not all wounds, you know, are the same. Not all patients are the same. Not all dressing regimes are the same. And what works for one patient might not work for another patient. And continual reassessment of that wound will help us, you know, understand whether that wound is improving, is static or deteriorating. Was the decision that we made when we did our initial wound assessment good enough to progress that wound towards healing? Are we on the right track? If we're not on the right track, that doesn't necessarily mean we made a wrong decision in the first place. It might just mean that that's just not working for that patient and we need to come up with a different option. And the Triangle of Wound Assessment, as we spoke about earlier, helps us to do that. We've done our holistic assessment. We've looked at the 3 different areas of the wound: the wound bed, the wound edge and the peri-wound skin. And hopefully we've come up with management aims based on what we've seen in those 3 distinct areas. So we need to document our wound assessment, obviously, and one of the things that we need to document is wound location. Whereabouts is it on the body? You know, what are the dimensions of that wound? How long has it been there and what is the likely cause? You know, wound location, for example, might determine what shape and size of dressing that you would pick for a patient. You know, not all shapes and sizes are suitable to go on different areas of the body, are they? So we need to understand whereabouts on the body that wound is, along with the dimensions. You know, do we need to use a larger size? Do we need to use something to fill the wound before we use a secondary dressing, for example? All really important information to capture. So how do we measure a wound? Well, we use the ruler method. So we measure undermining and tunnelling, and we also measure the depth of the wound as well. So when we do our wound bed assessment, we're essentially looking at tissue types firstly, and these are those common tissue types that you would see in a wound bed. So we'll go into those in a bit more detail. If we first of all talk about necrotic tissue, so necrotic tissue is can either be soft and wet or hard and dry. It can be black or dark brown in appearance, and essentially it's dead tissue, and it contains dead cells and other debris that collect on the surface of the wound. And there is no blood supply in necrotic tissue, so it's dead. And the longer it sits in the wound, the more increased risk of infection there is for the patient. So it certainly needs to be removed for that wound to progress towards healing. It increases the risk of infection, and it will stop that granulation tissue filling up that wound and those epithelial cells for resurfacing that wound. So it needs to be removed, but it needs to be removed carefully. And the reason we need to think about removal of necrotic tissue or not removing necrotic tissue is that what we know is that we need a blood supply for a wound to be able to heal, because our blood supply brings nutrients and oxygen to the wound, which will help with that granulation tissue filling in that wound and that wound progressing towards healing. So if there is no blood supply behind that necrotic tissue to support that ongoing healing, then removal of that necrotic tissue can increase risk for the patient. It increases risk of infection. And, what are we trying to achieve? We can't improve the blood supply to a wound. A patient would need ongoing specialist referral, perhaps to a vascular surgeon for that to be the case. So we need to be really sure before we remove any devitalised tissue that there is a blood supply to the wound to support that ongoing healing. And it's not always easy to see if there's a blood supply to a wound. In this image here, you can see on the slide, we can see that there is a blood supply to this wound because it's bleeding. But it's not always easy to see that. For example, if you've got a cap of eschar or necrotic tissue on somebody's heel that's covering that wound bed, you might not know that there's a blood supply behind that necrotic tissue. So you might need to do further investigation to understand what the blood supply is to that wound before you make any decision about whether to remove that necrotic tissue or not. So another tissue type might be sloughy tissue, and this again will vary in colour. It's usually yellow, but can appear grey or green in appearance as well. And again, it's made up of pus, it's made up of dead cells and material on the wound bed, and the longer it's there, the more delayed that wound healing is going to be. So we need to again think about, in our management objectives, if we are going to remove this sloughy tissue and how we are going to approach that in our treatment plan for the patient. Granulation tissue. This image here you can see is a lovely clinical image of healthy granulation tissue. It should be pink or red, and it's made up of new connective tissue and new blood vessels that will form on the surface of the wound during that healing process. Granulation tissue will fill in the wound from the base of the wound, and it will fill wounds of any size, but obviously the bigger dimension the wound is, the longer that process might take. Granulation tissue shouldn't bleed very easily, so if you've got granulation tissue which is what we call friable or bleeds very easily, then that might be a sign that there's some infection happening for that patient, and therefore we would incorporate that into our treatment aims and management plan when we're selecting what dressings we're going to use. Epithelial tissue is pink or white, and you can see, and it's often seen in the final stages of wound healing, the epithelial cells will migrate in from the edge of the wound to finally resurface that wound. But in wounds of larger dimension, you will see islands of epithelial tissue appear within the wound bed as well, which again will spread out and migrate across the surface of the wound to finally resurface that wound, and it will appear healed on that surface. So once we've looked at tissue types, we will move on to looking at exudate, and not just the level of exudate, but we also look at things like consistency or viscosity and colour of exudate as well. the level of exudate in a wound should reduce as the wound progresses towards healing. So we need to bear that in mind. So looking at the exudate itself, we make note of things like the volume, so how much exudate is there for this particular wound. Is it a very dry wound or no exudate coming from it? Or is it a medium to high level of exudate? And this is what we're documenting to help us make a decision about how absorbent perhaps the dressing is that we're going to select when we come up with our dressing or treatment plan. The consistency of the exudate can tell you a lot about how a wound is progressing. You know, if it's a very thick and viscous exudate, that might be a sign that there's an infection brewing for that patient. And the colour, you know, if it's a purulent exudate, then again, that might be a sign that there's an infection developing. So lots of information can be gained from exudate. So as well as our wound bed assessment, when we're looking at tissue types and exudates, we also move into looking at different signs and symptoms of infection that may or may not be present for that. So when we look at signs and symptoms of infection, we look at signs of local signs of infection that you might see in a wound, and then perhaps you might see a patient with spreading or systemic signs of infection as well. So just to pick out a couple of local signs of infection that might be evident for your patient during your assessment, the patient might experience increased pain that they didn't experience before. That might be a sign that there's an infection developing for that patient, or there might be an increased level of exudate. I said before that exudate levels for a patient's wound should reduce as the wound progresses towards healing. So if you're seeing increased levels of exudate or increasing levels of exudate, then is it because there's a local infection developing for that patient? Possibly, and you're going to need to incorporate that as a treatment objective in your management plan. And as that infection deteriorates, it may start to spread further than local to the wound. So the patient might start to develop a temperature, for example. The wound might start to break down, or the patient might have general flu-like symptoms and possibly even raised white blood cell count if you have access to blood results. So these are the things that we would make a note of when we're observing if there are any signs of infection. But a non-infected wound should appear without any signs of infection or pain and should be reducing in size. So just to sum up our wound bed assessment, we've looked at tissue types, you know, what colour is the tissue type, how much of that particular tissue type is there, how much exudate, what is the consistency of that exudate. Are there any signs of infection we need to be concerned about? What are the dimensions of that wound? Are there any structures visible in the wound bed that we need to be aware of and again incorporate into our treatment plan? And then once we've looked at the wound bed assessment, we move on to the wound edge assessment. I mentioned before about the epithelial cells resurfacing the wound and migrating across the wound surface from the edge of the wound. So we need to have a really healthy wound edge for that to happen in a timely manner. And these are some common problems that you might see as part of your assessment when you're looking at the edge of the wound. Maceration is a really common issue or barrier to healing that you might see at the wound edge. And essentially macerated tissue, and there's a really good clinical image here on the slide of macerated tissue, is waterlogged tissue, and it very often looks white around the edge of the wound. And it's an indication that there's either been suboptimal exudate management, so the dressing that's being used hasn't been absorbent enough to manage that wound fluid, or there's been an occlusive dressing which has trapped that exudate under the dressing and not absorbed it into the dressing effectively enough, and that can lead to this happening. With anything, or with most things, you know, prevention is better than cure, so we need to try and stop this from happening in the first place, or at least if we do notice it as part of our assessment, try and manage it as timely as possible to help get that wound edge back to its healthy condition where that epithelial migration can take place. Alternatively, you might have a wound edge that's quite dehydrated, so it isn't moist enough for those epithelial cells to do what they need to do. And in this image, you can see that there is some quite dry, devitalized tissue within the wound bed, again causing the wound edge to be quite dry and dehydrated as well. So the management aim in this situation would be to rehydrate the wound edge. I mean, firstly with this wound we'd need to get rid of that or debride get rid of that devitalised tissue before we can have a think about epithelial migration. But once we've got rid of that devitalised tissue through a process of adding some moisture to it perhaps, then we will hopefully have a wound edge that's at the right level of moisture for that healing to take place. We also need to know if there's any undermining, which can be another common thing that is found in wounds that are difficult to heal. So undermining at a wound edge can cause us a problem. And I do keep going on about epithelial migration, but absolutely, if your wound edge isn't at surface level with your wound bed, then those epithelial cells are not going to be able to migrate and resurface that wound. And certainly if there's an undermined space at the wound edge, there's an opportunity for exudate to collect. And if there's exudate that is allowed to collect or pool at the base of a wound, then bacteria has the opportunity to proliferate in that exudate, and it will increase the risk of infection for that particular patient. We need to know if there is any undermining, whereabouts at that wound edge is, and what extent that undermined space is extending to, essentially, because we need to fill that space when we're thinking about what dressings to use to prevent that pooling. Sometimes a wound might appear with a rolled or thickened edge, and wounds with rolled edges are difficult to heal because, you know, those epithelial cells again are not going to be able to do what they need to do to resurface that wound. So we need to address this problem to facilitate that process happening. Sometimes these patients will benefit from some kind of surgical intervention, but sometimes a rolled or thickened edge can be an indication that the patient might have a malignancy. So in that situation, if that's one of the concerns that we have, then we need to consider referring that patient for some further investigation into that. So just to summarise our assessment of the wound edge, we're looking to see if there's any possible maceration present at the wound edge. Is the wound too dehydrated? Then we need to address that in our management plan. Is there any undermining, and if so, what extent, whereabouts is it in the wound, and to what extent is the wound undermined? Or are there any signs of the wound edge that might need further intervention, like rolled edges as we discussed? So once we've done our wound edge assessment, we then move on to our periwound or surrounding skin assessment. And these are some of the common problems that you might see on your surrounding skin for your patient, and certainly do need to be incorporated into the management plan, because we need to avoid being blinkered and just looking at the wound bed, because if the periwound or surrounding skin is also unhealthy, then the likelihood is that the wound itself is going to be delayed in healing also. So we need to address all three areas and not just focus on one. So maceration we talked about at the wound edge, but if we don't prevent that, or we fail to address the problem when we see it being at the wound edge, then it can progress. And sometimes, as you can see in this picture, if that macerated wound edge isn't dealt with or managed effectively, then the wound exudate can cause problems further afield. And in this image, you can see this patient's heel is heavily macerated, and there is a risk in this situation not only of infection but wound enlargement. And if we don't address this problem, then all of that patient's heel could potentially break down. Excoriation is something else that you might see on the periwound skin or surrounding skin, and excoriation is essentially caused by repeated injury to the skin, and what we don't want is a patient who's scratching their skin or any break in the skin that surrounds the wound, because if there's a break in the skin caused by the patient scratching, then there is a risk of infection, because the skin will be broken, and that's a portal of entry for bacteria. If the skin is itchy for the patient, then use of emollients can sometimes be helpful in alleviating the problem, so we can reduce or prevent that itch-scratch cycle. Dry skin can also be very itchy. You know, the keratin cells can become flat and scaly, and the skin will feel rough, and you may even see visible flaking on the patient's surrounding skin. It can still be very itchy, and again causing the patient to scratch. So think about, you know, the patient scratching themselves and causing that injury, which can break the skin. We don't really want that to be happening. But if skin is dry, then it can crack without any patient itching the skin. So again, that's an increased risk of infection and something we don't really want to happen. When the skin is dry, the acid mantle is reduced, and therefore we've got reduced protection against bacteria as well. So, it's a problem that we really do need to address, and emollients again can be useful in this situation. Hyperkeratosis is a term that we use to describe an excessive build-up of dry skin or keratin. It's often seen on lower limbs, like patient's shin, like you can see in this picture here, but can also be found on hands, heels and soles of feet. It can also form around wound edges, particularly in diabetic foot ulcers, and will impede healing and cause a problem. Bacteria can proliferate in hyperkeratosis, such as what you can see on this clinical image here. So we really need to prevent it if possible, but treat it in a timely manner if we're able to do so. Callus is a term that we use to describe a thick build-up of dry, hard, avascular tissue, so tissue that doesn't have a blood supply at the wound edge, and particularly around the edges of diabetic foot ulcers. Thickened or the hardened part of the skin or soft tissue, especially in an area which has been subject to friction or pressure. And podiatrists are really skilled at using sharp debridement, for example, to pare that callus down and bring those wound edges back to surface level to help that epithelial migration. Eczema or dermatitis is inflammation of the skin, and it can often be very itchy, so again increases the risk of patient causing trauma if it's not dealt with appropriately. The cause of eczema is often unclear, but if it's seen on the lower leg, which is where I would imagine most of your patients would, or lots of your patients I should say, will experience eczema, it's often as a result of venous disease, and first line treatment for venous disease, as we know, is compression therapy. So that would be what we would be treating varus eczema for, along with emollients and sometimes topical steroids. So just summing up our periwound skin assessment, we've looked at the overall condition of the surrounding skin as being a really important part of our wound assessment, because we need healthy surrounding skin as well as a healthy wound edge and as well as a healthy wound bed. Healing wounds will display a flat, moist wound margins surrounded by healthy, intact skin. And in non-healing deeper wounds, wound margins can sometimes be surrounded by edematous, inflamed skin, which might be broken or painful to touch. So once we've done our assessment of those three different areas, we might have identified some management goals. So for example, as part of our wound bed assessment, we might have identified that there is some non-viable tissue or dead tissue that needs to be removed to progress that wound towards healing. Or we might have identified that there is an increased bacterial burden because we've seen some signs of infection. So we would incorporate both of those management goals into the treatment plan that we decide on once we've made our final diagnosis. The same at the wound edge, what problems or barriers to healing did we identify at the wound edge, and did we see any issues on the periwound or surrounding skin that we need to have a think about? We need to make a diagnosis, and that's ultimately why we do our wound assessment, because we need to understand the extent of what we're dealing with and what objectives that we need to identify to help progress that wound towards healing. And that's what our fundamental objective is. We will have clinical judgment perhaps about what we think is causing that wound to be there, and sometimes we get surprises that crop up as part of our wound assessment that we didn't really know about. So gathering information and being that detective, looking closely at the patient's past medical history, looking at their diet and nutrition, as well as looking at the wound bed, the wound edge and the periwound skin, are all ultimately designed to help us come up with that final diagnosis. But we need to continually review that diagnosis as well, because sometimes along that healing journey for that patient, other things that can crop up to cause a problem. So we need to always be identifying those as early as possible. So we're assessing wound characteristics to help us come up with that diagnosis, and all of the information that we've already discussed when we're looking at the patient's holistic assessments, when we're looking at the level of exudate, for example, is all information that we use to help us come up with that diagnosis and understand what caused that wound to be there. Sometimes we need to do further investigations, so we need to get a bit more information. We think we know what we're dealing with, but we just need to do a few more checks to help us confirm that we were right, or uncover or more barriers to healing that we didn't know about, or we couldn't see as part of our wound assessment. So for example, any wounds that's difficult to heal or non-healing, the patient might benefit from having some blood taken. We might uncover that the patient is anemic or has raised blood sugars. So that can be a useful investigation to do for patients. Patients where perhaps we've identified some signs of infection, maybe we've initiated an antimicrobial to deal with those signs of infection, but it's just not having the desired effect. We might decide that we want to take a wound swab to see what it actually is that we're actually dealing with. Is there anything different that we need to do? Patients with a wound on the lower leg, we talked a bit about blood supply and needing a blood supply there. So if your patient's got a wound on the lower leg and you feel from your lower leg assessment that it's a venous leg ulcer, you're wanting to put some compression on, but you need to check that it's safe to do so and how much compression it's appropriate to apply for that patient. So in that case, we would do an ankle brachial pressure index to understand if there's any arterial compromise which might dictate how much compression we are able to put on that patient's leg. And patients with diabetes, as you will know, will often suffer with some kind of neuropathy. So in that situation, the patients will often have pressure perception tests to try and understand the extent of that neuropathy. And then we think about our documentation. We've gathered lots and lots of information, and we need to make sure that it's documented in a clear and concise way. We only want to document the relevant facts as part of that wound assessment, because if we document facts that are not relevant, sometimes that can put us off on a tangent or take us down the wrong path, or make us be a bit confused about what it is that we're trying to achieve. So only the relevant facts should be documented, and documenting relevant negatives, things such as the patient not being diabetic, that's a relevant negative to record as part of a wound assessment. And a relevant positive is to document if the patient is a smoker, for example. Your documentation should be factual. Like I said, it should be relevant. It needs to be written as soon as possible after that assessment has taken place, because so that information is current and pertinent to the decisions that you make for that treatment plan for that patient. It needs to be written clearly, and that's not just for your benefit. It needs to be written clearly for any other clinician who might be subsequently seeing and treating that patient as well. Because we share information, don't we? I mean, patients don't have the luxury of seeing the same nurse every time to address their wound or to manage their wounds, unfortunately. So we need to have clear communication between not only clinicians within the same service, but cross-speciality. We need to have clear, consistent communication as well, and documentation will help support that. But we also need to confirm the action plan with the patient as well, because that's the reason we're doing that, isn't it? You know, we're doing an assessment to help that patient's wound to heal. So the patient needs to be on board with the decisions that we've made, the objectives we've decided upon, and the decisions that we've made around how we're going to manage those barriers to healing if we've identified any as part of our wound assessment. So we need to discuss with the patient what it actually is that we're going to do, what kind of dressings we're going to use, how often do they need to be changed, where will they be changed, and who will do that. Does the patient need any special investigations? Do they need to have an ankle brachial pressure index done, for example? Do they need to be sent for an x-ray? That might be another investigation that you've decided the patient needs. So they need to understand all of that information as well. Is anybody else going to be involved in their care? Are you referring them to anybody else, such as a podiatrist maybe, a dietitian, a vascular surgeon perhaps? The patient needs to be involved in that decision making. And details of any specific treatment. Some treatments are quite involved and complex. So compression therapy, for example, can sometimes be quite a complex treatment for a patient to be able to understand why they need to have that those bandages on their leg. So to improve concordance with that kind of treatment, they need to understand why it needs to be there. And, you know, at the end of having that discussion with the patient, we need to check that they actually understand what we talked about, because sometimes patients, in my experience, can just nod at you and say, yeah, I understand, when actually they possibly don't understand everything. So checking their understanding of what you've discussed and the decisions that have been made is really key as well, and also addressing any concerns that they might have. Non-adherence, particularly in chronic wounds such as venous leg ulcers or diabetic foot ulcers, is really common. And compression therapy can be quite an uncomfortable treatment to have, for example, and non-concordance rates, I should say, can be quite high. But we also know that recurrence rates of venous leg ulcers can be high as well if the patient isn't compliant or concordant with wearing their compression therapy once that leg ulcer is healed. So we need to educate that patient and empower that patient and help them to understand why that treatment is really, really important for them to have. But we also need to think about, supported self-care. If that patient is willing and is able to take part in their treatment, then, we should be exploring that as an option. We need to obviously do an assessment to make sure that they're suitable to take part in that. We also need to, think about the treatments that we decide on. Are they simplified? Is the patient going to be able to do it? So keeping the treatment as simple as possible, not making things more complex than they perhaps need to be. So just to summarise, wound assessment is a really complex process, and it helps us determine, what caused the wound to be there and how that wound is progressing over a period of time. Patient consultation is really key to wound assessment, and we need to have really good communication skills to be able to develop that rapport and get all of the information that we need to help our decision making, to help us make those good clinical decisions. There needs to be a systematic assessment, and it needs to be structured, and if we use a systematic wound assessment framework, that will help us gather all of the information that we need in a clear and concise way to help us make sure that we don't miss anything. And an example of a really simple, robust wound assessment framework would be the Triangle of Wound Assessment, which is what we've talked through on today's session. Wounds that don't show any signs of healing within 2 weeks need to be carefully reassessed to make sure that we haven't missed any barriers to healing that we needed to incorporate within our wound management plan. So just to recap the learning objectives that we talked about at the beginning of the session, hopefully you'll be able to now appreciate the importance of why we need to take a really detailed patient history, why we need to do a really careful examination of the patient, to help us identify any barriers to healing using a framework such as the Triangle of Wound Assessment. Making sure that we document our wound assessment really accurately, because that helps evidence the decisions that we make for our wound management plan to try and help that wound progress towards healing. And have a think about, which patients might potentially be able to take part in that supported self-care, take part in their own wound management. I'd like to thank you for listening to the session today. Hopefully you found it useful, and I hope I will see you again soon.